I'm not as good at the TED Talk stuff that James is, so I'm going to have to stand here. But yeah, so like Lars said, one of the hats I wear is running our Fontan clinic, but then the other piece of what I do besides my general cardiology clinic in Medford is that Christina and I run the lipid clinic. So if you refer to the lipid clinic, this is us. And my one disclosure is that this is a really big topic and I don't have enough time. So I'm going to try and talk fast and get through what I can get through. And I apologize if I really run, but that's why I need like a day probably. Okay. So here's my goals. We're going to really quickly review landmark studies for children, outline our current guidelines, discuss importance and timing of screening, and then talk about some management strategies for our kids, and then talk about nutrition recommendations. I'll let Christina take the ball for there. And then if we talk fast enough and we have time, then I have a couple of cases I'll run through with you guys too. Okay. I will start with this quote by Dr. Gerald Berenson in 2003, who who founded the Bogalusa Heart Study. Adult heart disease begins in childhood, and lifestyle changes have to begin then too. So I think that really sets the stage for what I'm going to try and talk to you guys about. Okay, don't worry, this is the only slide like this. But what are lipids? Why do we care? So I end up talking a lot about this with our families and just giving them some education about just the background on why this is important. But for us, it's fatty compounds that are poorly soluble in blood, so they have to be carried by lipoproteins. So lipids are things like cholesterol, triglycerides, and like our phospholipid cell membranes. And when you combine them with a protein, it's a lipoprotein. And for us to remember, there's really kind of two categories to try and just keep in mind. One is the ApoB lipoproteins. This is the stuff that cause atherosclerosis, which is what we're trying to prevent. The LDL cholesterol and all the little particles and the big chylomicron remnants. And then there's the ApoA lipoproteins, and these are the good guys. They are atheroprotective, and this is like the HDL cholesterol, or you'll hear people say the good cholesterol. Okay, that's it. We're not talking about any more of that. Real briefly, if you want more information on any of this stuff, I have so many slides that go into details, but I'm going to spare you. But these are really the main background kind of landmark studies of where we have learned all of what we know about pediatric lipidology. And there's so many more that have come since then. So the Bogalusa Heart Study, the Muscatine Study, Childhood Determinants of Adult Health, the Cardiovascular Risk in the Young Fin Study. There's just a lot. Anyway, so we really do know a lot about kids and cholesterol, even though it still feels like sort of a weird conversation to have with families sometimes. And this one's near and dear to my heart because I actually trained at Tulane, and I actually did get to work with Dr. Berenson and go out to Bogalusa, so I just like to mention this one. It was founded in 1972. Dr. Berenson was a Louisiana native, and he was a pediatric cardiologist, and it's an epidemiology study from birth until 26 years old. And really, there's thousands of publications, 5 textbooks, probably more by now, that have come out from this study. But one thing we did learn was that there's documented anatomic changes that occur between 5 and 8 years old. So we know that the process of heart disease with cholesterol starts in childhood. Okay. We're going to talk a lot about this too. So when we talk about heart disease and cardiovascular events, we do talk about screening and secondary and primary prevention strategies. This is it's a lot of adult stuff and less so with pediatrics, but ours is better. So secondary prevention is really those screening tools trying to detect early. Primary prevention kind of modifies the risk factors, and the goal is to intervene before the disease process begins. But what we do in pediatrics, right, is primordial prevention, which is really true prevention. So we're trying to prevent risk factor development of disease. So this is the best. Okay. I like to run through just real briefly cholesterol levels and how it changes with age through pediatrics, because it's helpful to know kind of why we screen when we screen. So at birth, it's very low, and then the cholesterol tends to pick up pretty quickly between birth and 2 years of age. So for me personally, I just don't find it very helpful to test for cholesterol for kids younger than the age of 2. It's just not, for me, it's just not helpful. And then it continues to increase, and then it hits a little plateau between 9 and 11. It's probably a trigger for you guys. That's the first time we screen. And then it takes a little dip during puberty, sometimes as much as 20% decreases during puberty before it picks back up again. So sometimes if we test then, we might get a little false sense of what their true cholesterol actually is. But it doesn't mean it's not a bad time to test. It just might be a little lower than it will be. And this is what it looks like in graph form. You see that little plateau between kind of 9 and 11, then it takes a little dip and then heads back up as we get older and older. It just keeps going. Okay. Some background on our screening, this is like why it's so important, right, guys? It's 1 in 5 adolescents will have an abnormal lipid panel. That's a lot. It occurs frequently with obesity and cardiovascular risk factors, which we would know intuitively as pediatricians. The severe high cholesterol, so an LDL over 190, occurs in about 1 in 250 kids and adolescents. That's a lot. Okay. And we also know from these landmark studies that significantly abnormal lipid levels track from childhood into adulthood, which that makes sense. And we also know that subclinical atherosclerosis I talked about earlier is abnormal in kids with familial hypercholesterolemia. So over time, this is what our screening is sort of has looked like. 2011 is really the first time we had published recommendations for pediatric lipid screening. And this is interesting because most of us, maybe me, I was done training. So I didn't learn anything about this even in my cardiology training because we didn't really think about it or talk about it. So then 2011 is when the AAP published their expert panel of integrated guidelines that you guys are very well aware of, that they recommend screening between ages 9 to 11 and then again between ages 18 to 21. So it makes sense with that graph. And it doesn't have to be fasting. That question gets asked. You can just look at the non-HDL number if it's non-fasting. And then I do kind of warn families sometimes that if they go in and it's non-fasting and it comes back really abnormal, we're going to have them go back and get a fasting. But if it comes back normal, then great. I'm going to skip that. This is the integrated guidelines. That little bubble is where the lipid stuff is. I'll blow it up for you. So universal screening, like we said, in those 2 timeframes, but then there's also kind of focused screening depending on their other risk factors and family history. This is also from that same 2011 paper. They also talk about high risk categories. I'm not going to go through all of the stuff with you guys, but I'm just going to call out that type 1 and type 2 diabetes does fall into this high risk population that needs to have earlier kind of targeted screening for their lipids. So then if we fast forward a few years to 2018, we have our kind of current guidelines actually that we really focus a lot of for management of blood cholesterol. And there was a little bit on pediatrics, but just not enough. And so the next year in 2019, the American Heart Association then came out with this cardiovascular risk reduction in high-risk pediatric patients. So those 2018 guidelines really did focus more on those targeted screening timeframes, so outside of our universal screening, and they called out risk factors such as obesity being the most prevalent, as we know, in our kids. And then in 2019, that kind of pediatric specific paper gave us kind of boxes of kids for high risk, moderate risk, and at risk populations. And those kids actually need yearly screening and earlier yearly screening, but it can be non-fasting. Okay, so how are we doing? I feel like actually we're doing better. Every time I give this talk, I feel better. It's still not widely used, but I am finding that as time is going on, I'm getting more and more referrals that are coming from pediatric practices and other practices too that are universally screening their kids. So we're doing better. We just need more physician provider education like we're doing, and more family awareness, which I think is out there. And sometimes it's often still a little tricky, kind of funny conversation to talk about cholesterol with families. But as these guidelines are getting more kind of circulated and there's more awareness campaigns, I think it's getting better out there. Okay, so this will be in your packet, like Eric had said. If you don't have it, it's all coming. What's acceptable and what's not acceptable, or what's abnormal. It's different than adults because kids are not like little adults. We know this. These are kind of our cut points that we go for. But if you are just doing for screening, this is the number we're looking at: 145 for non-HDL cholesterol is abnormal. I'll talk a little bit about familial hypercholesterolemia. This is a lot of what I do in my lipid clinic. It is common. It's an inherited form of high LDL cholesterol. The heterozygous form is common, I should say. Luckily, the homozygous form, which is a very severe form of it, is very rare. The autosomal dominant type is the common type, and the recessive type is rare. Clinically, they can have physical exam findings, but in kids, they do have them, but I think it's much less common to see. But it is still very prevalent in our general population. Probably 1 in 2 to 300 people in the general population have FH. There are clinical criteria that's been out there kind of in various countries, but ultimately, I often will send my patients to genetics because that's how we confirm it and make our diagnosis. Okay. So when do I get suspicious? If I have a fasting LDL that's over 160, I get suspicious that this could be FH. If the fasting LDL is over 190 and the patient's under 20 years old, that's all my patients, there's an 80% chance that they have FH. So, and it's important because half of men and a quarter of women with FH will have some type of cardiovascular event by the time they're 50. So super important to find these guys. And it's exciting. I get excited about it because we're really going to change, I think, the way our population looks as these kids get older. As we find them and treat them and get their cholesterol normal, that stat's going to change. So it's pretty cool. Okay. The other thing that's important is to remember reverse cascade screening, which I think as pediatricians is also really just such a good thing for us because we are really good about taking care of our kids. And then if we also then say, gosh, your kid has really high cholesterol, have you had yours checked? As dad has his checked, we're going to check all the siblings also. I've caught a lot of parents that didn't know that they had really bad cholesterol this way. So that's good stuff too. Okay. I'm going to talk about some management of pediatric dyslipidemia because that's what we really want to know about. Okay. It's abnormal. Now what do we do? So first step, kind of actually before step 1, is to make sure we're not missing something. Make sure we're ruling out any possible secondary causes that might be making their cholesterol elevated, like diabetes, some other renal problems or thyroid disorders. There's lots of tables of this. I'm not going to go over all of it, but there's lots of secondary causes of dyslipidemia, Kawasaki's disease. Okay. So after we've made sure we're not missing something like a thyroid problem, then we talk about lifestyle modifications. And this works. This does. And it even has effects on working for kids that have genetic lipid disorders. It may not get it down enough, but it does have a good effect, short and long-term benefits to lipid levels and subclinical atherosclerosis. Family-based approach is probably the best approach to help the kids, but also probably help the whole family in the process. Exercise recommendations, nutrition recommendations, healthy weight, blood pressure, normal glycemia. This is like what you guys do every day. And if they're obese, then we have to have sort of a more intense plan for them, and sometimes even a healthy lifestyle clinic referral is helpful. There are recommendations out there for exercise, and it's a dose response dependent on lipids, meaning the more they do, the more their cholesterol will drop up to a point. So it really, exercise will lower total cholesterol. It lowers the LDL cholesterol and triglycerides pretty nicely, and it will raise HDL cholesterol. And so sometimes just, gosh, these kids that maybe aren't moving hardly at all, if we could just get them moving their bodies a couple days a week, we're going to start seeing some improvements, even if they're not getting to our kind of ideal goals. So just getting them motivated to get out and move really does have some really good positive effects. So preschool age kids, there's not any specific recommendations. We just want kids to be kids, get out, active play, love being outside, just love doing just active play for them. And then there's more specific recommendations when they get a little older. So between 6 to 17, about an hour of moderate intense activity every day of the week. So about 7 hours a week is what we're ideally shooting for. And then I do go on to kind of talk to them about if they can get to a higher intense level, maybe 2 or 3 of those 7 hours, then they're going to get even more kind of effective lipid lowering. Okay, this is how we start. This is step 1, nutrition, physical activity, and then tobacco avoidance. Okay, so we've tried that. What next? This is oftentimes where I kind of take the reins, but it doesn't necessarily have to be that way. So the next step is to talk about medications, and when do we start talking about putting kids on a statin with their lipid control? So looking at that 2018 guidelines, if a kid or a teenager 10 years or older with an LDL that's persistently over 190, or if it's persistently over 160 and we're clinically very suspicious of FH, and they didn't respond enough to 3 to 6 months of lifestyle changes, then that's the point where we start talking about medical therapy with a statin typically. And sometimes we'll even consider statin therapy lower, like in a 7 or 8-year-old, if there's a really concerning family history, if their LDL is extremely elevated, or if they have an abnormal lipoprotein little a, which I'm going to talk about in a sec, don't worry. And obviously there's a lot of decision-making and discussions that happen with the family kind of all the time, anytime we start a statin medicine. Okay. Lipoprotein A, maybe you guys have heard about this, maybe you have not. In 2019, actually, the National Lipid Association did put out a statement paper that all adults, there's a lot about this in there, but all adults should be tested once for this in their life because it's such a significant risk for early cardiovascular events, so early heart attacks and strokes. So if you have not had yours done, it is time. I had mine done several years ago. It was normal, luckily. Okay. And then they updated their recommendation in 2024 to include recommendations for kids. So if they're under 18 and we suspect that they have FH, or if they have a first-degree relative with a history of early cardiovascular disease, if they have an ischemic stroke for unknown cause, or any first-degree relative with elevated Lp(a), then they too should be screened. So most all of my kids, by the end up in my clinic, they end up getting an Lpa test as well. So what is it? You'll hear people say, it's the other bad cholesterol. It is. So it's an LDL-like particle. It's genetically transmitted, so this often runs in families. The Lpa gene is fully expressed by the time they're about 1 or 2, but it doesn't fully reach adult level until they're like 5 or 6, or maybe I should say 6 or 7. No, I'm kidding. I had to get it in there at some point. Okay. Fully expressed by the time they're 5 or 6. And so I have had more than one family actually that know that they have LPA in their family and want to test their kids. And it's it's okay to test them when they're younger, but knowing if you test a 3-year-old that's normal, it's not quite done expressing. So we would have to test them again. So I like to wait until they're at least past 5, because then we just have a better sense of what it is. And it really is not going to change my management to know about it sooner. So we just wait. But it's a very recognized independent risk factor for early heart disease. And it's high in about 20% of the population. And it is right now really annoying because the lifestyle therapies don't change it. Statin therapy doesn't work on it. Actually, there's really no specific medication that targets LPA yet, but it's coming probably in they keep telling me 3 or 5 years, and then they keep saying 3 or 5 years. So I'm going to keep saying 3 or 5 years. So I'm not really sure when, but there's a bunch in process. Okay, let's talk about statins. So for the most part, this is our first line medical therapy after lifestyle modifications. It's clinically proven to reduce mortality and cardiovascular events in adults, and it's really effective at lowering LDL in kids and adults, and it's really well tolerated with very little side effects in kids, which is very nice. Looking at that 2019 kind of paper, you can risk stratify your patients based on those disease processes like diabetes. You can see LPA is in that moderate risk category. Maybe you can't see it. I'm going to read it for you. And then the at-risk kids are obesity and a very, very long list of other things. And then it talks about when you should treat. So if you're moderate or at risk, the threshold to treat is 160 for an LDL. And then if you are at the high risk category, threshold to treat is 130 for an LDL. Okay. How about statin? What do we know about statins in kids? We actually know quite a bit. There's quite a bit out there and several decades of knowledge. So we have short and kind of medium term information, but of course we don't have lifelong information yet. But I am seeing parents in my clinic that have been on statins since they were kids. So we definitely, yeah, I know. So our knowledge is getting better and better. So there's this. This was from 2007. There's a meta-analysis of 6 studies, randomized, double-blind, placebo-controlled trials. Awesome. It works. We learned that it works. But more importantly, there's no difference between the placebo and the statin with occurrence of adverse events, sexual development, which we used to think there was, muscle or liver toxicity. So that's cool. This is just a list of some of the statins. They're all approved for FDA approved for kids 10 and over. Some of them are approved even younger, like rosuvastatin to a 7 or 8-year-old for FH. Here's some other drug therapies that we do use, ezetimibe being kind of the next one. Sometimes we use it first if the parents are very nervous or kind of averse to a statin, or we can't use it for whatever reason. And the bile acids, I just can't remember the last time I ever did that. They're really not tolerated. But the slide is even, or this table is not even accurate anymore. This is from 2021 from the National Lipid Association. But the injectables like evolocumab is now approved. Actually, I just went to a conference this fall. It's now approved for kids 10 and over for heterozygous and homozygous FH, genetically confirmed. So if we have to go to the injectables, then we can do that with approval starting at 10. So that's cool. Okay, when should I refer? Right? This stuff's like, we didn't learn this stuff. Okay, if we have a suspected or known FH, if we've got abnormal cholesterol despite lifestyle and diet modifications after 3 to 6 months, if you want numbers, if the triglycerides are over 300 or the LDL is over 160, but honestly, anytime. We just had a kid that came to us and their panel was 100% normal. And they were just scared and they had a family history. And it actually was, I think, a really good conversation to talk about their normal and what's not normal and family history. So we were totally fine doing that. So here's some key points. Then I have a couple more slides. How are we doing on time? We okay? I'm not even looking. Okay. Adult heart disease begins in childhood, and lifestyle changes have to begin then too. Primordial prevention is our true prevention. Emphasize a heart-healthy lifestyle across the life course. Remember universal lipid screening, which we're doing better. And then also remember the targeted screening starting at age 2. You can do this non-fasting. Don't forget the family. And statins are the first line as far as drug therapy. And then I threw in 2 slides about triglycerides because we just don't talk about it. And this really could be like a 3-hour talk on triglycerides. So I have 2 slides. There's no triglyceride lowering medications in pediatrics that we have safety and I can't say the word, you can read it. We don't have anything approved that we can use in kids, but we do. So we've got fibric acid derivatives, omega-3 fatty acids, niacin, which I don't use, but nothing's FDA approved, okay? But in the 2019 statement from the American Heart Association, it does say look at their risk factors, determine their risk, and then consider treatment. So they do talk about it. So it comes with that panel. So we screen, when we screen, fasting is much better for triglycerides because it is really wild how big the changes are if they go in fasting or non-fasting with triglycerides. Lifestyle changes really work, and I feel like the triglycerides take a dive down. The first improvement we see is with them. And then we decide if they need treatment kind of based on how severe it is. And sometimes the numbers come back high, or they feel high, like a triglyceride of 200 feels high. That's mild. It's on a different scale than LDL cholesterol. Moderate high triglycerides are 400 to almost 1,000. And then we talk about severe high triglycerides over 1,000. So the scale is different. So sometimes 200 sounds bad, but it's a little abnormal. Okay. I'm going to let Christina take over and talk about nutrition, and then maybe we'll make it to the couple of cases. We'll see. Okay. I try to go fast. Okay.
I'll be quick. Okay. Hi, everyone. Do I just press enter, right? Yeah. Okay. I'm just going to go over the official guidelines. So these are in your packets too. So we start with a step 1 of kind of approach, where that's that first 3 to 6 months where we're like, okay, let's rein this in a little bit, and we look at a little moderate fat reduction. So that's saturated fat at 10%, like 8 to 10%. And then the cholesterol less than 300, looking at I don't really talk specifically to families about the mono and polyunsaturated. It's just too complicated. I really just focus on the saturated fat less than that 10%, and then no trans fats, and really looking at the fiber at that 5 to 10 grams. So, and then if that doesn't work and we want to escalate to the step 2, then we look at this, and that really pushes it to that less than 7%. And then I talk a little bit more seriously about all the fats and things. Just taking that full picture, less cholesterol, and still that maybe more towards the 10 grams of soluble fiber if we can get there. This is after that sort of initial kind of phase. So the primary things I'm talking about is really just trying to get the families to understand, let's reduce that saturated fat intake and increase fiber. And that usually gets all these points in. So decreasing saturated fat foods, so that's coming from animal products, tropical oils. So red meats have more saturated fat than lean. Of course, I think we all know that. So that just gives you a little kind of idea of how that changes, right? 8 grams versus 3. So I'm talking a lot about meat swaps that we can make, skinless chicken, lean beef, lean cuts of beef if they need it, fish and seafood, skipping fried meats, which would be like all year. So then that talks about the fast food side of things. And then limit the high-fat meats as well, so salamis and sausage and bacon. I recently had a kid that was like, oh no, I eat salami for a snack all the time. So little things like that, and then deli meats. And you can make some of these other swaps like chicken sausage and turkey bacons and things, but again, those are still highly processed. So I'm not like, just do it and great. I still talk about like maybe there's other ways you can have that protein. Plant-based proteins, of course, so beans and legumes, tofu, tempeh, nuts, and seeds. We talk about this a lot, just all the different ways we can. I'm a little bit of a detective with them. Like, okay, well, what could we try instead? What product is out there? Dairy is a big component of saturated fat. So a whole milk, a 1 cup is 5 grams. Some yogurts can have 8, grams of saturated fat in there. So I am talking a lot about swapping that to non-fat or low-fat, limiting cheese intake, and really that's so hard for a lot of these kids. And so I kind of I'm realistic, and I think, well, if you're snacking on cheese, can we maybe stop that? Can we have it only at one meal? Maybe a stronger tasting cheese, you can use less of it, and then you're getting a little less amount. So little things like that. Baked goods and sweets, obviously with all that butter in there. And then the oils itself. So swapping butter for more plant-based, higher kind of good, healthy fat oils. Coconut oil is a tough one that the research, I just read a study that, said it did on par with olive oil, but we think, well, it's so high in saturated fat, and then other studies say it's not good, so maybe the extra virgin coconut oil might have a little bit better profile of the type of fats in there, so that might be okay-ish. All of them are better than butter. So I guess that's a good take home. And then there's some specialty oils like flaxseed oil, rich in omega-3s. Okay, fiber. This is a tough one because kids don't love all these foods. So the recommendation is really looking at that soluble fiber, but that's not identified on a label. So I'm talking about trying to push them to 20 to 30 grams of fiber a day, and that should get them that 5 to 10 grams of soluble, if that makes sense. Fruits and vegetables a little higher in soluble fiber, I'm always trying to push those, as well as the vegetables. Whole grains don't have a ton of soluble fiber, but they're still good, so I talk about them. And then beans and legumes, and then your chia seeds and flax seeds are nice kind of supplement things to add. Oats do have more of the soluble fiber, so we do push that. So your oat bran, barley, rye, quinoa kind of have more of that than like your whole wheat breads and your whole wheat pastas, but they're still important to get for the fiber part and all the other things it does for our bodies. So limiting added sugar and ultra-processed foods, of course, is important, and really pushing water, non-fat, low-fat, unflavored milk, watching our juice intake and soda, so that's not changing. And added sugar in foods, I like to kind of just walk through a label sometimes with family and, say, well, every 4 grams that you're seeing on there is a teaspoon of sugar. Is that what you want to eat in a granola bar? Do you want 3 of them? So could we find something a little less? And then just trying to really think about other snacks they can do. Do they have to eat chips all the time? Like, what could we try instead? So I'm sure all of you have the conversation as well. It's tougher in my teens, but we get there. Supplements. So there's a lot of research on stanol and sterol supplements, 2 grams per day, not above 3. Like there's no benefit to take a ton of these above 3 grams per day. There's the pill, that cholesterol is what we talk a lot about for kids there's a large pill. So for kids that don't want to do that, there's the chews. I looked so hard to find what other foods are out there beyond the spreads. And there just aren't. I think in the UK, maybe there's some yogurt. I think Benecol made a yogurt at one time and they don't anymore, which I was really bummed because I think it's hard. Like the Benecol spread, you have to have like a lot of it. I don't know. It's like, so maybe you could split, well, maybe you use the spread for a couple things and you take a couple pills because you have to take like 4 pills a day. So, yeah. And then there's this juice apparently, but I have yet to see that in the store. Has anyone seen that? Sometimes these heart healthy, heart wise things are on there and that's because they've added the stanols to it. So that's for the LDL kind of side of it. For triglycerides, as Maggie mentioned, the omega-3s. So We're definitely putting kids on that with high triglycerides at 1 to 4 grams per day. I really love this Barleans. Has anyone tried it or heard of it? It's at Costco. It tastes really good. Okay, it's like a lemon sorbet or like different flavored sorbets, and so really good on yogurt, smoothies, even by the spoonful. It does not taste fishy. It's quite amazing. And so I like to push that one if they won't take a pill. Otherwise, there's the Nature's Made fish oil pill is great. And then there's the prescriptions, Lovasa and Vascepa, is the other one, which is a great option for insurance coverage. Fiber supplements, we really want that soluble fiber from psyllium. So there's the dosing there. You could do the capsules or a powder drink like Metamucil, which, is a tough one. It's a tough sell, right? But, if you have a teen who's willing to just chug it really fast, it could work. You have to take a lot of the capsules, so that's why I kind of have the conversation about the powder, but most people are like, I'm not going to do that. So, and then, the mainstay is really this Mediterranean diet, really pushing a lot that exercise is so important, and then really looking at all these foods from the ground and plant-based items and a sprinkling of the meat and sweets at the top. So common questions and barriers I get. Obviously, my kids won't eat vegetables. Like, what do I do? You all have dealt with this. And, I listen to them. I understand it. I keep trying to just encourage them to be consistent in the exposure. If the kid's eating fruits, I'm like, hey, there's a lot of great fruits that can have some high fiber. Let's just really focus on that while you don't ignore the veggies. Keep doing the hard work, right? And hopefully that gets them a little bit of their fiber. Eggs, I do say eggs are okay, not like 8 eggs a day or anything, but like an egg a day is fine. It's just not that the LDL is not there. That's affecting the heart disease risk. So we do, if they really love their eggs, I say, take a yolk out and scramble up extra whites for them or something. Busy schedules, eating out is a part of that. I don't have time to make meals or meal plan, right? So just really working with them to come to where they're at and be like, okay, if you do have to go out, could you not get the soda? Could you skip the fries, get the grilled item? Like, where could we go that might mitigate some of that extra saturated fat and sugar? The cheese one I kind of talked about. So I really do just we'll talk about quantity and frequency and see what little changes they can make. They won't eat the beans or the fish. Again, that's, there's a lot of ways you can incorporate beans. I know people think I'm crazy, but you can put it in muffins and make brownies. So there's ways to try. You just have to be willing to think outside the box, I guess. And same with, tofu and nuts. Nut butters can work if that's something that they just don't want to eat. Nuts, almonds, and walnuts and hazelnuts are the 3 that tend to have the highest sort of impact on lowering LDL from the studies I've read. So I feel like almonds are popular. I don't know about eating walnuts and hazelnuts all the time, but I like them. I haven't noticed a lot of kids being like, oh yeah, I take handfuls of walnuts, but it's good to try. And then cooking, right? So trying to just mitigate the extra fat that they're using in cooking. So air fryers are great. And then I kind of talked a little about the coconut oil and coconut milk. And then food insecurity, just really trying to figure out how we can provide as much resources for these families to eat a diet that's a little less processed, which is very challenging. But resources that we can provide for families, these are some websites I really like. We have a Heart Healthy Plate that we created. It's for adults, but it's more or less the same. There's an alcohol component, right? But otherwise, it's pretty much the same. And just additional, the foodhero.org has a lot of recipes, which I love, and it's in Spanish and English. So I really encourage that one for families. There's budget friendly. You can get it less than 30 ingredients, less than 30 minutes, less than 5 ingredients, whatever. So lots of ways you can specialize or personalize the recipes. and then ways to stretch their food dollar. That was fast, but.
Are we still good, Eric? Oh, dang it, okay.
Let's see if we have questions. Maybe we could do one case. Let's just see that.
Okay.
Let's take questions real quick. Thank you, you guys. That was great. Any questions? Yes.
I actually have a few questions, but one is, I know at least I see a lot of kids really struggling with like portion sizes. Do you have any tips or like resources that you use, or more of like just the snacking without paying attention to how much we're actually eating?
I really use the plate, which I know this new pyramid is out there, but I ignore that and I use the plate because it does help give a visual of portions. And so I kind of really work with them on that. I don't, measuring out your portions and all that is just like too tedious, but the plate is really, they can grasp that. And then, just really trying to encourage a structure in their eating, like grazing is not going to help us. So really, hunger is the greatest spice. It's just like it works, right? So if we can stop the grazing, they might come to the table and actually eat the veggies you made because they're hungry and they didn't fill up on crackers, all day. So those are my two biggest approaches for portions.
My other question, when you're talking about statins, like I know at least a lot of patients I've had, their hyperlipidemia, but then they also have an elevated A1C. And then when you kind of decide like metformin versus statin, can you do both?
Yeah, you definitely can do both. And I do have quite a few families that see both of us, meaning they see me in the lipid clinic and they see our endo team to help them with their A1C. So I have patients that end up on both. Yeah.
We've had recommendations too in our clinic, at least from endocrinologists, specialists around here, so wanting us to start a stimulant to decrease appetite. I don't know if you speak on that at all. We've had it at least a few times over the last couple months. So
That's interesting. Okay, I'm going to reach out to them. I don't know how I feel about that. This is the first time I'm hearing. I haven't encountered it yet, so I'll ask them. But
Is it more like Vyvanse?
I think it's Vyvanse. Well, they don't really
Okay.
say, they just recommend a stimulant, but like we had another presentation that said Vyvanse, but not really any direction. I can't remember. It's it's around here because we were in Hillsborough, so it's definitely I think it's either Randall's or.
anybody else cardiology out here have opinions on that?
All right, I think I have two hopefully quick questions. You mentioned Kawasaki's disease and cholesterol. Are you talking about kids who had a history as a kid? Like we should be screening them differently now that they're older?
Yeah, that's part of their
okay.
risk. Yeah, they're at increased risk.
What
So
age
they
should
go
we
in that
start?
the targeted screening.
2-year-old. Okay, okay, good.
Yeah.
Good to know. Thank you. And then you mentioned the puberty timing too and how that affects the cholesterol level. So if I have a kid that's slightly older, above that typical 9 to 11, but they haven't started puberty, should I still be doing it?
Yeah.
I'm just trying to get the parental buy-in of
Yep.
our timing, and then sometimes it takes a while.
100%. Yeah, I think that happens a lot. So if they've never had it and we missed that 9 to 11 and you have them and they're captive and they're willing, I would just get it done.
What about
Yeah.
if they're already 10 or 2 or 3, but they're 9?
Yeah,
And
just
so
get it done.
Just get it anyway?
Yep.
Okay, great.
Yep.
Thanks.
Okay, one last question, then we'll switch. Sorry, we didn't have time for your cases today.
It's okay. I tried.
I just wanted to clarify, from your perspective, would you encourage PCPs to be considering starting statin? Or if we're in area theoretically to refer to you, that should be the first step as opposed to starting some of these?
Yeah, I guess that's really hard. I think most of us as pediatricians are uncomfortable with starting and managing a statin, which that is very reasonable, myself included, because we did not learn about this, right? So I think it depends on experience and comfort. It's not it's you should not be doing this. I think it's just going to take time, I think, for everybody to learn about it.
It seems like there's a lot of things that PCPs are needing to get comfortable with. And so I'm wondering
I know.
if this is one of those that we
I know
need to
this
get
is so
comfortable with.
hard, and it's just me, right?
Yeah.
So I'm happy to see everybody, but I'm gonna our clinic is booked,
Yeah. And how
And so
far-
I try and like get people in, and if they're local to Medford, I'll just see them in my like normal clinic. But I think the more everybody gets used to this,
Yeah.
that like we're gonna need it.
Yeah.
Yeah.
'Cause how far is your wait list right now? I'm just curious.
I don't know.
Uh-oh, that's never good.
It's like a few months. It's at least a few months out. Yeah, at least through April I'm booked. Okay, yeah, I don't know.
All right, let's give Maggie and Christina another round of applause. Yeah, I have a feeling we're going to be talking more and more about this topic in the coming years, right?